So hopefully both Debbie and I will be able to address some of the questions that came to us, because the most important thing is that you get out of us being here the questions that you want answered. Quite often we'll tell you what we think you want to know, but it might not be relevant. So just one tip, for those of you that are too polite to check their phones, Belgium is in the lead at the football. So why are people affected differently? And we've already covered this in that neuromuscular disorders, including myotubular myopathy, there's a spectrum. So what are the respiratory complications that are experienced with myotubular myopathy? So the general muscle weakness can lead to respiratory muscle weakness, and then that affects individuals in three potential ways. We have heard already that the respiratory muscle weakness can lead to hypoventilation, and depending on the severity, it may be seen in the day or immediately, or in those with milder conditions, it manifests at night, because that's when we put our breathing muscles under the most stress. Some individuals will have a decrease in their chest wall compliance, and that's just because they can't take a deep breath in. And what you get is shortening of the intercostal muscles, the accessory muscles, and that means that you can't then get a bigger breath in. So not only do you have the fact that your muscles are tight, but you just also then can't actually get them to open. Whilst other people may just have an ineffective cough, and that can cycle to recurrent respiratory tract infections. And we've already heard that for nocturnal hypoventilation, we want to provide ventilatory support for that. And also if individuals are on daytime ventilatory support, again, we want that to be optimal. And there is some evidence that actually starting non-invasive ventilation, and this is why Anita already alluded to this, that if a child has recurrent chest infections, or an adult, but there is no evidence of nocturnal hypoventilation, she would have a low threshold to start it. And what we've seen in 3 studies in children is that after the initiation of non-invasive ventilation, there's a decrease in the amount of hospitals days per year, the hospitalizations per year, but also the severity, they're requiring less PICU stays. So delivering non-invasive ventilation for recurrent chest infections is evidence-based. So what can we do when someone has a decreased lung volume? How can we maintain lung function? And that was a question that's already been coming through today. So this is an individual who has a chest wall deformity. The provision of non-invasive ventilation saw a significant change in their chest wall deformity, and you might just say to me, well, they look a little bit more chubby because they've had a gastrostomy inserted, but I do have serial pictures of no difference until, because they were a bit slow to use it at the start. So you can see that delivering non-invasive ventilation with a pressure span of at least 10 centimetres of water can start to bring out the chest wall. And what we're aiming to do is to eliminate any paradoxical breathing in order to get a better chest wall shape. This is a child who would have developed chest wall deformity had they not received non-invasive ventilation, and they had it at a very young age. And there is a slight deformity of the chest wall, but it's nowhere near as significant as what we would have seen had they not had it. Now, how can we do lung recruitment? And I appreciate there are people here from different countries. Typically in the United Kingdom, we tend to use a lung volume recruitment bag, and that's pictured here. It's an ambu bag. It has a one-way valve built into it, and it's attached to a mask or mouthpiece. And what you do is you deliver a breath in, the valve closes, you can deliver another breath in, another breath, another one if you want to, but that huge hyperinsufflation will stretch the chest and it will maintain the range of movement, the same as doing any other passive movement. If you're in France or you come from Australia, you'll probably be given an Alpha 300 device. And in Germany, you might be given a bird in order to stretch your chest wall. All of these devices provide a positive pressure, the same as the bag, but a deeper breath in, stretching of the chest wall. And if we look at air stacking, what this does is someone's breathing away by themselves, and what you do here is you deliver a breath in with the bag, followed by another one, followed by another one, followed by another one, potentially a hold, and then the individual breathes out. And you can see that there is a massive change in the tidal volume that the person achieves. You can also use this technique to improve cough efficacy. And that's very simple if I demonstrate now. So if I have very weak muscles, so I can't really breathe in, and I cough, you can hear that that's quite a small cough, whereas if I can get a deeper breath in, my cough efficacy is already quite simply improved. Management of chest infections is a multidisciplinary approach, and it's multifactorial. We have our medical management, we have secretion mobilizing techniques, and we also have cough augmentation techniques, and all of it needs to be used in tandem. One of the questions that we have had is what's the correct order for inhaled medication? And this is taken from a general recommendation, but does include medication for cystic fibrosis called Dornase alpha or DNAs. And there are some individuals with neuromuscular disease who do take DNAs to help break down secretions. It's not evidence-based, but sometimes it works in an acute infection. And what you would do is you would take this at least an hour, possibly longer, prior to airway clearance. If someone has a wheezy chest or that they're prone to chest tightness or bronchoconstriction with the addition of saline, you would have inhaled bronchodilators. You would wait at least 10 minutes, and then you can deliver normal saline or hypertonic saline at different doses. You perform your airway clearance techniques or your cough augmentation, and then you would have your inhaled antibiotics if that's prescribed, followed by inhaled steroids. And obviously, if you're not having one of those treatments, not everyone needs all of them, you just go down to the next stage. So if we look at secretion movement, this is normal ciliary function in an individual with no problems. And you can see the cilia are beating, and that will move your secretions up towards the mouth. What happens, it's always the way, your video clips never work. Let me see if I can get this one working. Here we go. So this is just an individual with a cold, and you can see that the ciliary function is affected. They don't have cystic fibrosis, they have no genetical problem with their cilia. So the ciliary function is impaired with the extra thick secretions. Normally when we breathe, we take a deep breath in and our flexible airways expand, and then they contract when we breathe out. That creates an expiratory airflow bias, which moves the secretions towards the mouth. And that also can be affected by viscosity, the depth of the liquid layer, positioning, and gravity. When we look at hypertonic saline versus normal saline, what are the differences and how does it work? So if you have hypertonic saline, and this again is in a cystic fibrosis patient, but this is your healthy epithelia, and what the hypertonic saline does is it increases the liquid layer. It draws water with the salts into this layer and helps move the secretions along, and that's how it works. There are various different doses, so you could try initially normal saline and see if this moves the secretions, or you could move up to 3 or 3.5%. And if that helps, but it's not enough, you may move up to 7% as a maximum dose. And what you're looking at is whether you feel any bronchoconstriction, so whether you feel any chest tightness or whether your oxygen saturation dip if you're not able to do formal lung function testing. So that's how we would assess what works. However, what I would like to point out is it's always a balance. So you can quite often have hypersalivation within the mouth, but dry secretions on the chest. And even by nebulizing things into the mouth, you could make the hypersalivation, there's just more water within the mouth. So you need to look at what are you treating. So is it thick secretions within the chest? If that's what I'm treating, then yes, I would consider hypertonic saline. However, if you've got thick secretions at the mouth, thick secretions on the chest, but you're taking something to dry everything up, like a hyoscine patch or glycopyrrolate or something like that, then you need to adjust that dose. Delivering hypertonic saline is not going to solve the problem. You've just dried the individual up too much. So it's that balance of what you're trying to achieve. Another question that came through was, does salbutamol help? Would you give it to a young infant? What situation? Would you do it when they're well or routinely? And again, it's going back to what is the problem. So are they, when I listen to their chest, can I hear wheeze? And is it a wheeze due to narrowing of the airways? And if it is, then I would try giving salbutamol in that instance. If the wheeze only comes when they're unwell, then you would only give it for the period they're unwell rather than routinely with no end date or no reassessment. If someone isn't able to tell you that their chest is tight or that they feel wheezy, then what I would be looking at is what's happening with their oxygen saturations. If I'm stressing them a little bit, I'm doing physio, I'm irritating them a little bit, are they dropping and it's not really phlegm moving and I don't feel the phlegm moving? In that instance, then yes, I would try salbutamol and see where it is. Again, there's the balance that you don't want to drive someone's heart rate, which is a consequence of giving salbutamol. You can make the heart beat faster. I wouldn't want it to drive it up into a very high rate that could potentially cause problems. So it's that balance of where we are. And I don't tend to give it routinely unless there is someone that has a co-diagnosis, and that one can be quite hard to tease out, but it's not uncommon that you might have neuromuscular disease and you might have asthma. And that in that situation, then yes, we would give bronchodilators routinely. Other things that you may find is that someone who has had recurrent chest infections gets colonised with bacteria. So for example, Pseudomonas aeruginosa is grown in the sputum regularly. In the first instance, what we would aim to do is eradicate the Pseudomonas with oral antibiotics, possibly intravenous. And then what we look at is if they're having a recurrent respiratory tract infections because they can't cope with the load of the Pseudomonas, then would we prescribe oral or enteral prophylactic antibiotics? Or do we look to providing nebulized antibiotics? And we found that actually in our spinal muscular atrophy population that providing nebulized antibiotics has decreased the amount of hospital admissions, the amount of secretions if someone is colonized with it. And you want to get the best deposition for it. So what you would do is you have your ventilator with an antibacterial filter, a piece of tubing, a leak port, and what you would do is rather than have a vented mask, you would have a non-vented mask because you want to make sure all of the drug is getting to the patient. So they're breathing through the T-piece and the nebulizer and they're breathing out at this point. Or that you can put a catheter mount if they have a tracheostomy here. So it can be something that can be quite useful, especially if you're finding that you're running into problems. So with regards to respiratory physiotherapy, and I could probably talk all afternoon and Debbie would shoot me, but what you're trying to do is you want to determine where the secretions are. Are they in the central airways? And if they're in the central airways, you're looking at using cough augmentation techniques. If you have secretions in the periphery, then you want to use secretion mobilizing techniques. And if you have a combination of both, you're going to be using both techniques. We have a whole host of options available to us, and this is too small for you to read, but it's just to say there are options out there, and I will give you some reference papers that you can get free, and I believe they're linked on the Myotubular website. I'm going to start by talking about secretion mobilizing techniques. So these consist of chest wall clapping, vibration or shaking. So a cupped hand and you work your way round the chest. And if someone requires ventilatory support, you should do this technique on ventilatory support rather than taking someone off it. And a question that came in is why do we recommend 30 seconds and then for you to have a rest? And the evidence base for this is that longer than 30 seconds of percussion can cause fatigue, and that's manifested in an oxygen desaturation. And that was based in the cystic fibrosis population, but clinically we have seen it in other individuals. So what they looked at was if you're able to take deep breaths or have an augmented tidal volume and you do 30 seconds of percussion, you don't see any oxygen desaturation. So depending on what area you're treating, you can percuss for 30 seconds, have a rest for 20 seconds or so, repeat, and you do 5 minutes each area, whether that's the front of your chest, the lateral aspect if you're positioning for one side or the other, and your treatment time takes that amount of time. Lots of people ask about vibrations or shaking. And what that technique is, that you're placing your hands, this is where I need my dummy. It's a heavy one.
And the nice assistant.
We always do a double act. So what you would do is you would place your hands and you're going down in line with the ribs and you're shaking. You haven't got a sturdy enough table, but you're going down. And if you've got small hands and a big person, what you're going to do is you're going to be targeting on one area for some vibrations and then you can target on the other area. But again, you're going in line with the ribs and you're always doing it on the breathing out. And if you think of a ketchup bottle, what you're doing is if you're clapping, you're shifting the secretions off, and if you're doing vibrations, the chest wall's quite hard, but you will get some movement. But if you actually shake and you do a stronger manoeuvre, you're going to get more of that phlegm moving. The question is, do manual techniques work? They're not really evidence-based in the neuromuscular population, and there was a meeting last year sponsored by the ENMC looking at what physiotherapy techniques work in neuromuscular disease. And an international group of experts looked at various techniques, and they were surveyed. Going round to number 10, 10 is the best possible thing. So manual techniques, which are in blue, and positioning, which is in red, are basically cheap. They're available. They don't require much cooperation of the individual, and there's some skill in teaching it. But they're appropriate for infants, children, individuals with tracheostomies, people with bulbar weakness, and those with scoliosis. So the consensus is that manual techniques, although they're not evidence-based, and Anita touched on this in her talk, that they are useful. So other techniques that you may find people mentioning are the VEST, or high-frequency chest wall oscillation, or intrapulmonary percussive ventilation. And what these techniques do is, this video clip's a bit blurry, but what they do is they shake the chest either internally or externally, and that moves the secretions from the periphery towards the central airways. If you're on ventilatory support, you do the technique in conjunction with ventilatory support. Or for those of you from France, Belgium, the Netherlands who have heard of intrapulmonary percussive ventilation, you breathe in through a mask or a mouthpiece, and that causes internal vibrations within the chest but can provide ventilatory support at the same time. I would use them if someone had a high secretion demand. So you were finding that despite the techniques you're using, you're doing lots of physiotherapy. If treatment times are long, if there's recurrent chest infections, despite the best management that you can have. And the thing to say about the secretion mobilizing techniques, they will mobilize to the central airways, but they're not going to help your cough. You've still got to get rid of them. Looking back at the panel of experts, when it came to high-frequency chest wall oscillation and intrapulmonary percussive ventilation, it was felt that intrapulmonary percussive ventilation was more effective. And if you look at the evidence, it is more effective than high-frequency chest wall oscillation. It's just in the UK and certain other countries you can't get it. It doesn't require any cooperation. Teaching is really easy, and it can be delivered not in infants particularly well, but children. So the company says over 3 years old, although we've used it slightly younger, tracheostomies and bulbar function. Something else that people have suggested is that the mechanical insufflation-exsufflation devices, or cough assists, because there's now more than one on the market, so we're now having to call them what they do, which is mechanical insufflation-exsufflation. They have a vibration feature on them. This is what it looks like with no vibrations. This is what it looks like if you give vibrations on insufflations, the deep breath. And here you can see this is the positive pressure in, small amount of vibrations, a slight interruption in airflow. This is on exsufflation, so when it sucks out, or you can have it on both. There's no evidence that it improves cough strength, but they haven't looked at whether it improves secretion movement. And however, the interruption in flow is just quite short. So the consensus at the moment is that actually using a dedicated device that gives oscillations, either the vest or intrapulmonary percussive ventilation, will be more effective. Another technique is modified autogenic drainage, or chest wall strapping. So you can actually use a bandage to hold someone down, but here Gemma is holding someone at a low lung volume. So that's here. So you just literally, oh, sorry, it's always the way, you flick on it. So you're holding someone at a low lung volume, right at the bottom, and what you do is you hold them down there, they're breathing away on the ventilator or by themselves, normal tidal volumes, and what you find is that the phlegm will start to move from the periphery, it will unstick and it will move, and you'll feel them vibrate under your hands and bubble, and you come up to the next level, and you come up to the next level, and then when they're high enough, we need to clear them. There is more of an evidence base in this area, and again, it's a cheap technique. It's relatively easy to teach, and you can use it in infants, children, individuals with tracheostomies, and people with bulbar problems. So it's something that might not be so popular where you are, or it might be a very popular technique that can be quite useful. So we've moved the secretions up, but we need to improve cough efficacy. So for all of you that see a physiotherapist, they should formally assess your cough. And that's just, it's not good enough just to say, can you do a bit of a cough for me, or look at someone and go, I think that's okay. So what they should be doing is they should be looking at the breath in. Can you see a good rise and fall of the chest wall? So can you see a deep breath in? And that's probably, if you have a weak cough, that's not going to be the case. Can you see paradoxical breathing? Do you see the intercostal muscles coming in? But also what's happening to the glottis. So if someone isn't on a ventilator, ask them to say E, 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 E. If they can sound an E continuously, it means that the bulbar function of the vocal cords is intact, and cough, and we usually say that the bulbar function is normal. If it's slightly deranged, or unintelligible, then the glottic closure isn't intact and the vocal cord function isn't working. And in that situation, improving someone's cough can be extremely difficult. And again, for the expiratory component, are you seeing a good abdominal contraction? You're not going to see that from me. And it should be measured. Okay, it's really simple. It's a paediatric peak flow meter to get the best readings, because it's graduated for low flows. A full face mask, because when we cough, we open our mouth, otherwise you'll lose stuff. And literally, a 3-year-old and above can perform it. So a deep breath in, and what you're measuring is your peak cough flow, which is this part. So it's the peak expiratory flow that comes out when you cough. And for anyone over the age of 12, it should be 360 litres and above. There are predicted values based on centiles for children, so we can look at if it's less than 50% predicted, we're going to be needing to instigate something. People often ask, well, what technique and when? What do I use? And this is based on anyone that should be able to perform a peak cough flow of greater than 360 litres. It takes into account the cost of the technique and how much assistance is required. But there are various techniques to improve cough efficacy: glossopharyngeal breathing, a manually assisted cough, an assisted insufflation, which is the bag, the Alpha 100, the bird, even a ventilator, combining that with a manually assisted cough, looking at mechanical insufflation, exsufflation, cough machine devices, and mechanical insufflation, exsufflation with a manually assisted cough. And if your peak cough flow is nice and high, nothing needs to be done. If it's sitting here around 300, 270, these techniques will work adequately for you. But when your peak cough flow starts to drop to less than 160 litres per minute, or if you're a child, less than 50% predicted, then a mechanical insufflation exsufflation device is going to be the device of choice in order to improve cough strength the most. And this is just to look at, so you just have a visual representation of the techniques. A manually assisted cough, the insufflation via either of these methods or the various different mechanical insufflation-exsufflation devices that are on the market. I'm sure most of you know exactly what mechanical insufflation-exsufflation is, but just a reminder, it's a device that gives a deep breath in either via a mask or it can be via a tracheostomy, followed by a rapid switch to negative pressure. Ideally, the patient coughs or the individual coughs at the same time, and that shears off the secretions only from the central airways, either into the mouth or so that they can be suctioned via the tracheostomy or the mouth. And it can be repeated for as many cycles as is needed to clear the secretions into the mouth or until someone becomes too tired. And again, that's a balancing. So the questions that we had around these devices are, when should I have one? Well, it depends if you actually need one. There are other techniques that might be far more effective at higher peak cough flows than a mechanical insufflation-exsufflation device. So I'd want to know what your peak cough flow is. Have you tried the other devices? Have they failed? Because there was a study by Luncombe et al. Looking at those with higher peak cough flows. You actually produced a greater change in your cough strength with an ambibag and a manually assisted cough than with a mechanical insufflation-exsufflation device. So my view is that if you're having recurrent chest infections despite other techniques, then you should have one. If you're having lots of secretions, you should have one. If you're weak, you should have one. And if you have a tracheostomy, you should have one available to you. If your current regime of suction, manual techniques, hyperinsufflation is not working. How many cycles and coughs do you recommend? And it's always talking about coughs, makes me want to start to cough. So if someone is well, I always tell them that they should be using their device at least once a day. I usually say twice because I know that if they're anything like me, if you're told to do it twice, you'll do it once. And the reason for that is that even if there are no secretions present, you need to be familiar with that device so that if you are unwell, you're not getting it out the cupboard, panicking, how do I put it together? But you can use it on a daily basis to check your chest. Is there more phlegm there, no phlegm there? Is it working for me? Can I feel that my cough is stronger when I use it? Because if I can't, the settings need to be adjusted. But most importantly, you can also use it to maintain chest wall stretching and help with any chest wall deformity. Cycles and coughs, it depends on your physiotherapist. A long time ago, when they first arrived, I used to think, well, you need to do some deep breaths in and then have maybe 1 or 2 coughs out. Nowadays, I will set it up in an automatic mode, very simply, breath in, suck out, maybe a pause, breath in, suck out, maybe a pause, and I'll let it cycle. Because what you can do is the individual will let it fill up their lungs, they should just let it deflate their lungs, inflate, deflate, and when the phlegm starts to move, because that will move a bit from the periphery, and when it starts to get into the central airways, they can cough at that point. But my other view is that you don't know when someone wants to cough. Is someone always going to cough on the 3rd go? Or do you actually need 4 or 5 coughs? And there are some days you need 1, some days you might need 10. So you should have that flexibility so that you can go as long as is needed. And if they're on a tracheostomy, you can feel when it's moving in the tube and you know when to take it off at that point and you'll see it moving. There isn't a right answer and there isn't a wrong answer. So it does depend on you as an individual, but that's just how I've evolved my practice over the last 20 years. Can people use it more frequently when they're unwell, or should they just stick to twice a day? No, you should use it, if there's phlegm there, you should use it to clear your chest. And ideally, if someone's saturations are greater than 95% on room air or on their ventilator with no oxygen entrained, when you're starting to drop down below 95 to the low 90s, it's usually due to phlegm there and you need to clear it. But you do need to be aware of fatigue. Coughing for anyone is tiring, so you need to put rest periods in. This is a question that already came up, how young have I used it in? The youngest person I've used it was 3 months with very sensible settings, but for the best efficacy I find that 1 year and above, because you want to try and have the coordination, you want to have the individual, even if the cough is very weak, but trying to cough at that point, and usually before that point, nasopharyngeal suction, oral suction, manual techniques tend to work quite well. But if there was someone that wasn't doing well, then we would obviously trial them with a device. And if they held their breath, they cried, they didn't like it, you stop. Doesn't mean you can't reintroduce it in a month's time and just see how they get on. Is there a maximum number of cycles that you can give? No, but you do need to be aware that someone may fatigue. You're not going to go on for hours and hours and hours, but I might do 10 lots of insufflation, exsufflation, and then just see where the secretions feel like they are. What happens if you swallow air? And this is a really common problem with mechanical insufflation, exsufflation. Some people have gastrostomies, and so it's quite simple. You can either open it and all the air comes out, or you can draw back and that relieves the problem immediately. But if you don't have that, it's really uncomfortable and it stops you using it. So I suggest that you try it in a more upright position. You might have longer pauses between the insufflation and the exsufflation just to let things settle so that the air's not been blown straight back in. You might have longer rests between it. I often say just let the machine take over, because sometimes if you sort of like go as the deep breath comes in, some of the air will go down into your stomach, and you do see people when they're using their device sort of trying to take a deep breath in with it. You just need to let the machine give you a deep breath in. The only point that you need to try and do is to cough at the point that it sucks if the phlegm is ready to come out. You could look at decreasing the insufflation pressure, because that's what's going to be driving it down, and increasing the inspiratory time if that's appropriate. We've talked about the pause, and maybe it's the fact that you use it a little bit more little and often as opposed to one big go in order to get rid of everything. With all cough augmentation techniques and everything, it may be that you need a combination of things. So I just wanted to put this final slide up just to say, look, it's not just about cough machine devices. It may be that you do need a vest as well, that you do need a ventilator, that you're making sure that feeding is stopped at the right time, and that you have all the equipment you need. As I've said, there are 2 papers, and Anita alluded to one earlier that was the first one that's in the ENMC guidelines, and this one that's published in Respiratory Medicine, which I want to thank the Myotubular Trust for paying for it to be open access, so you can just download it, read it. If you have anyone that isn't sure of what technique to use, when they should be using it, or how they should be using it, both of these papers cover it, and hopefully it will be a resource that you can either take it to people. It's an international one. There are names of physios, physicians that are very interested in this area for all different countries, and you can get people to contact them. So I've got a big red sign that went from 20 minutes to 10 minutes, and then now says time up. So I'm stopping there.
Thanks, Michelle.